We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together.
The one thing that's tough is that I don't expect patients to fully be experts in whatever's going on, right? That's not what they're there for. That's what we're here for. We do our best, both you and I try to educate the patients as much as we can. To have them necessarily responsible of sending that message to other people on their care team is a little bit like playing telephone. Say, well, I went to this doctor, or, I went to this guy and they told me this and that, and like, I don't think that's totally true, or maybe we're missing something, right?
Yeah.
And what can we do to help each other out?
We are super excited to be here today on the Healthcare Revolution podcast. Today I'm meeting with my friend, Dr. Jie Luo. He is an expert he's a board certified anesthesiologist, an expert in neuromodulation, and he specializes in the spine. Welcome to the podcast,
Hey,
Dr.
thanks
Luo.
for having me. I'm excited to be here.
Yeah, it's great to have you. This guy is an absolute genius in pain. And we're lucky to have him on the podcast. So let's just kind of talk about the history of what we started doing back working at St. Mark's.
I think you were one of the first people I met out there.
Hopefully left a good impression.
I'm here, so must have meant something.
Yeah.
So I think I joined St. Mark's beginning of 2020.
Tell us about the clinic that you work in.
Yeah, so we're at the St. Mark's Interventional Pain Clinic. So a lot of what we deal with, our kind of bread and butter, so to speak, is really kind of spine-mediated pain. Really, I see our role as good diagnostics, trying to figure out, why people are coming and hurting, and really to provide them with a range or a menu of options, right? What are reasonable things to do to treat their pain and figure it out as a team.
So many people are wanting that nowadays. In the past, everyone wanted doctors to just tell them what to do. Mm-hmm. Like, what is it I have to do? Right. And doctors were trained that way, just to give you the answer. But nowadays, people want options, right? How have you seen that work in your clinic?
Well, I think, honestly, that's been in the patient's favor. That's what I think is the right thing to do. Now, there are certainly sometimes...
And why do you say that?
Yeah, there's certainly sometimes people still come in, hey, what do you think, doc? What do you want me to do?
Yeah.
And in those cases, I still... I give them recommendations as if I were in their shoes, right?
Mm-hmm.
If this were me, this is what I would do. But the tough part is, I think a lot of patients have their own lives to live, right? They are obviously there for a particular problem. They're trying to get an answer. Mm-hmm. But there are other things going on, right? There are personal relationships. There's work that they need to get back to. They have families to take care of.
Absolutely.
And so... I think it's tough to say, hey, you have to do this or that, right? And sometimes they may not have the time to do it. They may not necessarily have, the financial ability to afford certain things. And so my kind of philosophy is that if we can give them a range of options, right? Every single thing that we can do to address their problem, then we can really make the best of whatever situation they're in.
Yeah, I'm thinking that comes to mind is the evidence-based triangle that a lot of us know. And for those who don't know it, the evidence-based triangle is at the top you have the clinical expertise, which is the expertise of the healthcare provider that you're working with. And then at the bottom of the triangle, and these aren't necessarily in a necessary order, but the bottom of the triangle is, what does the research say? Mm-hmm. And then at the other portion of the triangle is, what's the patient's preference?
Right.
And if we were to put a dot anywhere on that triangle, it's different for everyone. Right?
Absolutely.
Sometimes we might rely more on the research to guide us. We might rely more on the clinical expertise here. Like, in my experience, this is what I've seen. And sometimes we might rely on more the patient preference.
Right. Absolutely.
It's like, what do you actually prefer? And giving them that wide variety of options. I love that.
Yeah.
And you're so good at that. I remember back working at St. Mark's, and I believe you approached us. You came to us and you said, as a therapy team, we should develop these rounds where we get together, talk about difficult cases, and regularly communicate on these patients that are not progressing, so that way we can be all on the same page. Tell me where that philosophy all started.
Yeah, I think a lot of that came from my training. So I did my fellowship at OHSU in Portland, Oregon. And the pain clinic I trained at there was really, it was called the Comprehensive Pain Clinic. But it was truly very comprehensive. We all, I think,
who was on the team?
Anybody you can think of. So we had the physicians there. We had physical therapists. We had chiropractors. We had pain psychologists. We had an excellent naturopath who. And
in my mind, I'm thinking like every time you say this, I think like a strip mall, and it's like
yeah,
they're all lined
right.
up. Is that kind of?
But I mean, anything we had. I mean, we had acupuncturists there. Anyone that you can think of that would be involved in kind of taking care of chronic pain patients, we had. Not only were we in the same clinic, but we all worked in the same room. I mean, there was a huge room with a ton of computers and workstations, and we just all worked together.
That is what the revolution's all about.
Right. So that was kind of the model that I trained in, right? And so for me, it was very easy to turn around and say, hey, I got this guy. He's got a lot of musculoskeletal issues, and obviously we're trying to deal with some of the underlying medical conditions, but I need this guy to go to physical therapy, right? What can we do there? Or, he's got a lot of kind of muscle scar tissue, and what can we do from a chiropractic or even acupuncture standpoint to treat that, right? It's unlikely that one single person is going to take care of all of it.
Yeah.
So it was really nice to have that resource. Coming out here, it was difficult. I joined an existing practice in a hospital, but there really wasn't necessarily set up resources for that. You really I had to basically start over, right? And find all these new connections and resources.
Ultimately, that's a patient's dream.
Correct.
Right? To be able to walk into a comprehensive clinic and be like, I have all these options. Can you guide me on where to start?
Right.
Right.
And it was tough because the first couple of patients I saw, I'd say, hey, we know what's going on. These are the couple things that we can do. Either, some medications that help with the pain acutely, or some injections that we can kind of think about. But what you really need is physical therapy, right? We need to get you back to doing what you want to do.
Yeah.
And so they said, yeah, no, that sounds great. So where should I go? I didn't have a great answer. I just moved here. I don't know where to go.
I don't know any PTs.
No,
in the
I
area.
have no idea. And even asking some of our staff around, they said, well, there's all these kind of clinics here. I'm like, well, so where do I send them? And they didn't have a great answer. And I don't even necessarily remember who I talked to, but you guys were part of the hospital at the time, right? The physical therapy clinic.
Yeah, we just had started the outpatient physical therapy right in St. Mark's Hospital, and we were wanting to do the same thing.
Right.
We were like, we got to connect with all these providers.
So I think that was just maybe fate or fortuitous timing. But
what advice would you have for like some young student or some young graduates that building these bridges with physicians is like impossible in their minds? What advice would you have for them?
I'd say go and reach out. I hope maybe that, when we first met that I came across that way, but we should be easy to talk to. I don't think we should anybody on the healthcare team should really feel nervous or hesitant about reaching out to somebody, right? That's not the attitude we want to portray, right? I never want to have anybody say, oh, I don't really want to text this guy and bother him, and he might be annoyed I'm calling him at whatever hour. No, that's not true. We're all here for the same reasons, right? And we all want to make sure that we take good care of our patients.
Yeah.
And if there's something urgent enough to call about, I'll pick up. I don't care.
Yeah, I mean, just this morning, I've talked to 3 patients over the phone about their plans and made adjustments, and I have talked to 2 physicians that were collaborating care and a coach to one of my Olympian one of my Olympian patients. I mean, that's what it's about. They're quick conversations to keep the ball rolling, keep us on the same page, but that's the team you want.
Right.
The team that's going to do that for you, because if we're not connected together and everyone's on the same page, the patient included, what do you see happen in your experience? Tell me of an experience or something like that can kind of guide us.
Yeah, so I mean, the one thing that's tough is that I don't expect patients to fully be experts in whatever's going on, right? That's not what they're there for. That's what we're here for. We do our best. Both you and I try to educate the patients as much as we can, right? To let them know what's going on, why we're doing the things we're doing. But to have them necessarily responsible of kind of sending that message to other people on their care team is a little bit like playing telephone.
Yeah.
Right. Things get lost in the translation, and sometimes I'm sure you've come across say, well, I went to this doctor, or, I went to this guy and they told me this and that, and you're like, well, I don't think that's totally true, or maybe we're missing something, right?
Yeah.
And so I think having that direct conversation is just really, really helpful.
Mm-hmm.
One of the stories I like to kind of bring up a lot, and this is, not like an overtly complicated case, but it does illustrate quite a bit why we're doing this. So a couple of years ago, I saw this, I think mid-40s, really, really just the nicest teacher. She taught, I think, 4th or 5th grade, really nice woman. Came into clinic and just said, gosh, I've just been having this, back pain for 10, 15 years. I'm a school teacher. I'm up and down all the time, chasing after kids. I've really hadn't had any time to take care of myself, but summer's coming up, got a little break. I'm kind of sick of this.
Want to enjoy the summer.
Yeah, exactly. So let's try to figure out what it was. And so, we got some imaging done, examined her, and ultimately our thought was that, she had SI joint pain. Again, hadn't really done very much, sent her to physical therapy, was, moving better. We did a couple of SI joint injections, gave us good diagnostic information. She said, yeah, every time we numb it up and put steroids in there, it feels a lot better. I was able to move a lot more.
That's why I love doing injections.
They're helpful, right?
Hone in. It's very diagnostic.
Right.
It's not going to be the solution. Sometimes it can be, get people feeling better so they can move better. But ultimately, it helps you determine that's the root cause.
Right. You know what you're treating.
Yeah.
But the best part of that is about 6 months in, I got a call from her physical therapist, or a text actually. Big paragraph, and
6 months in?
6 months in after this, right? Because every time I see her back, she's like, oh man, I feel so much better, and I'm moving and I'm doing really well. But I get this text one day from her physical therapist and says, hey, you know what? Would you mind putting in an x-ray for her hip? Because I really think she might have some hip issue going on. And I said, oh, okay, yeah, no, absolutely. I don't see her as much, right? We do our injections. I follow up, after a while, and she keeps doing physical therapy. And so I called her physical therapist back, and she said, yeah, she is progressing really well. But
so she had treated her for 6 months?
She was really diligent about going to physical therapy.
A long time to be in PT.
Yeah, I know. This was like a model patient.
Yeah.
And functionally doing a lot better, but she was complaining of this like kind of a groin symptoms and things like that. And so absolutely.
Very classic for hip type stuff.
Very classic. So we get an x-ray. Horrible hip, severely degenerative. And so we started looking into that a little again, and I think she ultimately ended up getting a hip replacement. Did fantastic. And it was one of those things where she had been hurting for so long, and she got so much relief out of the initial thing that she kind of ignored the other symptoms a little bit.
So it's almost like she had the hip pain and the SI pain.
Right.
But the SI pain was worse, so they started treating that got better, and then she started having hip pain as well.
Or noticing it more, and I think there's some interplay, right?
And ultimately, her SI pain probably came on because of her hip pain.
Sure, yeah.
And then it just got worse.
I think likely what was happening is that she had really terrible hip arthritis, probably was avoiding, or change her biomechanics to kind of compensate around it, and her SI joint was her kind of signal of something isn't quite right? For sure. But if her PT had never reached out, I don't think I would have gotten that x-ray.
That is the one thing I love about being in PT is that we regularly get to see people, and we get to see when something's not right. And then we get to engage and say, this isn't right, Dr. Luo, this is your world, can you help out, right? Because it's really the only profession that we get to consistently see people over time.
Correct.
And see how they progress, digress, or stay the same. So it's super critical for us to make calls, right? And to my profession, to make calls faster, right? I believe we could make calls a lot faster. I mean, the average plan of care in our clinics are 6 to 7 weeks, right? 6 months is a really long time. So hopefully we can make decisions quicker to get people out of pain more efficiently,
And that's I think that's the part I do rely a lot on our physical therapy colleagues, is that you get to spend so much more time with these patients, right? You get to see them several times a week.
And actually challenge them too.
Right.
See them move.
To have, put your hands on them and really kind of see what they're doing. The reality is that as much as I'd like to spend tons of time with our patients, we are kind of limited, right?
Yeah,
And
for sure. And it's not your role either.
well, it should be.
I mean,
but
go lift
reality,
weights
right,
and see them move.
Right. Reality is reality.
You don't have the space to
Right.
do it. And the functional medicine piece is your role too, but it's all about utilizing each other too.
And being
As a team.
good at what we're doing, right? And I do get that question quite a bit, when we see these patients, and I tell them, hey, I got this great physical therapist I want to refer you to, and they say, well, can't you print off a couple exercises for me to do? I'm like, well, I could, but it's so individualized, right? And
For sure.
and that's why we work together. We want to make sure we're individualizing
I've
care.
talked about this before on the podcast, but I've had physicians reach out to me in the past, like, hey, can you give me just a list of exercises that I can do for this condition, for back pain? And I really think about what I'm going to say, but most of the time I say, do your glasses work for me? And I don't mean to be condescending at all. Not, but like, your glasses and the way they're customized for your eyes is just as customized as exercise.
100%.
And the thing is, I can give someone an exercise, even being as skilled as I am now, and it hurts them.
Mm-hmm.
Right? But I give that same exercise to the next person with back pain and it helps them.
Right.
But my job is to monitor it so closely so I can customize it to how they're progressing.
Exactly.
Right? And make those tweaks, because I can't even print off a bunch of exercises for random back pain if I haven't evaluated them.
And the worst thing that can happen is that these patients go home and do them, and they're hurting because it's the wrong thing to do, and they say, well,
PT didn't help.
It didn't help. This is terrible. I'm never doing it again.
For sure. And that's not what we want, right? Because ultimately that could be the answer, but the dosage of what we do, the volume of exercise, the intensity of exercise, the frequency of exercise, how we do that determines a lot if they're successful. Right. If we dose it wrong, sometimes we give them the wrong idea.
Absolutely. And you can turn around and do the same thing with us, right? And say, hey, give me 3 injections we can do. Mm-hmm. Well, depends on what it is.
Yeah,
right? So
let's do some diagnostic,
right?
Some tests to actually get closer to what we anticipate it being.
Absolutely.
Tell me about how rounds has evolved now. What does it look like? And how have you seen it kind of evolve throughout Utah?
Yeah, so that's a great question.
Because we started, I remember it was in a space, like a little tiny room.
Yep. We were just sitting around in a bunch of chairs, trying to find some time over lunch to go over these patients.
Yep.
I think it's gotten a lot more streamlined and kind of not protocolized, but my gosh, what is the word? They're a lot more intentional, I guess I'll put it that way. Right?
They're planned out.
Yeah.
People, you have certain speakers rather than just a discussion. Right. Someone's presenting, and then questions.
But I think that's fantastic, right? I mean, we're all trying to make efficient use of our time.
Mm-hmm.
But I think a lot of rounds that I'm seeing these days have a small educational piece, right, bringing everybody kind of up to speed on what's going on in our realm.
Mm-hmm.
But leaving time to talk about patient care, going over difficult cases, going over shared patients, and I think that's the utility of these rounds. The other part of it, kind of going back to what we were talking about in terms of why these things are important and why networking is important, is another, I think, a benefit of these rounds is to meet new people, right?
Mm-hmm.
Who are folks that are either new to the region or new to the space, and what can we do to help each other out?
I think that's a key component to this revolution, is all about, if I don't know what you do, it doesn't mean I'm an expert about what Dr. Luo does. I just need to know what procedures does he do that I can guide my patient to. Because if I don't know what is in the menu, how can I even direct patients to where they need to go if they're not getting better in my world?
Yeah,
right?
We don't know what we don't know.
Yeah, right? And those rounds give us an opportunity to see. I came up when Sydney presented. She's our vestibular gal, right? And I'm like, I hope this shows people what she really does, because
I would have had no idea.
Yeah, how did that help you know what she did as a PT?
Well, it's funny because I've talked to her a whole bunch before that. I mean, we've met at rounds together, we've gone to dinner together, and she's always mentioned it, right? And I'm like, oh yeah, that's pretty cool. And I maybe it has to do with like balance and stuff, but that whole other component of how in depth it is with treating patients with migraines and vestibular symptoms, eye opening, right? And so now, knowing that, right, if I ever have come across a patient with any of those issues, then I say, hey, I may not be an expert in this, right? Or maybe I've kind of maximized the things that I do, but now I have another resource.
Yeah, absolutely.
Yeah, that I wouldn't have known about 6 months ago.
I right now I have this gal. She's a younger gal that she's going to be the top 5 in the nation for downhill skiing. This girl is so talented. Wow. She's been treated for about 8 months and just not progressing. And she is seeing chiropractic. And this is an extreme example of being over-medicalized, because we're talking about bringing the system together, which the majority people struggle with. But I'm going on the other end now of the extreme of we way overdid it.
Too many cooks in the kitchen.
Way too many cooks in the
Sure.
kitchen. She's young, so she can't really comprehend a lot of this. And she's got a spinal surgeon. She's got we thought was a PT. It's an athletic trainer. She's got a chiropractor. She's got an acupuncturist. She's got a personal trainer and a coach. And none of them were on the same page. So we got chiropractor twice a week. We got acupuncturist 3 times a week. I didn't even add massage therapist twice a week. Coaching 4 times a week. Personal trainer twice a week. You can see how like she's been over medicalized.
Oh, absolutely.
And everyone's giving her their own plan. And she's been doing this for 8 months now. And still not back. She can't get on the hill to ski.
Yeah.
She's still having excruciating pain. And the surgeon calls me and says, I need your help. Like, I don't even know what to do with this girl. She has nothing medically. It's all like, I don't even know, but I know it's your world.
Sure.
So I jumped in. I said, first of all, we talked. We got deep into her, evaluation and really determined, is this a musculoskeletal injury? Turns out it wasn't. She's just been stuck in the chronic pain cycle.
Yeah.
And I diagnosed it really as over-medicalized. She's confused. She doesn't even know what to do. And she's doing way too much and exercising extensively and not allowing her body to reset. So what I did is I said, are you okay? Someone needs to take the lead on your care, right? And ultimately it's you. But I realize you need some help here. Who would you like to take the reins? It doesn't matter who it is, but someone needs to communicate with everyone. She said, okay, I want you to do it. I said, okay, well, if I'm going to do it, I'm going to develop the plan. So let's develop that plan together. So we broke it down and we decided what's been helpful. These 2 things. Great. We're keeping those 2 things. We're going to take everyone else off the list. So we're going to take chiropractic out, acupuncture out, your athletic trainer, your personal trainer. Who do we have to keep on the team right now? We'll just put those on hold. We'll come back to them. We'll introduce them if needed.
Simplify it a little bit.
We got to simplify this. She's been complex, or it's just become a complex situation, right? And she's been so confused. So we got all that off on the plate. So we're only doing 3 activities a day with certain criteria and saying we can't progress to phase 2 unless we've met this criteria. And I'm going to communicate with your coach so they know what's going on. I'm going to communicate with your mom and dad, and we're going to be on the same page, and you're going to give me daily updates because we got to get this dialed in. If you're going to be top 5 in the nation, we got to get this dialed in.
Yeah.
And we'll get you back to your personal trainer. We'll get you back to your athletic trainer to do that high performance stuff, but let's get you through the rehab process first. And it's been mind-blowing, like how confused, over-medicalized she's become. And this is a very small percentage of patients, but it happens.
Yeah, absolutely. Yeah, same here, right? I think because people want help.
Yeah.
And sometimes if kind of going back to what we talked about earlier, if we kind of leave patients in charge sometimes, which obviously you want them to lead the team, but they're not experts in this, right? I don't expect them to fully understand the pathophysiology of spine pain and what options there are out there. Someone needs to kind of quarterback it for them.
Yeah, I love that.
And it becomes hard when, especially for a high level athlete like that, right? They're trying to get back to doing what they want. And I think the general philosophy of a lot of those, high performance athletes is that I just got to train harder, right? And sometimes that's not necessarily the answer. Sometimes it is to scale it back.
Doesn't mean you have to rest.
No, right. But to do therapeutic movements, right? I think working out, and as cool as deadlifting like 300 pounds is, that's not super therapeutic. And sometimes if you have an injury or something that's kind of holding you back, we really have to kind of step back and try to figure out, what it is that's going on.
Focus on what you can do without pain, and then we'll build that capacity over time.
They often will go back, right? Yeah. But it's getting them there. I think that's the difficult part.
Yeah, tell me why spine-related pain can be so persistent over time.
Yeah, lots of reasons. The spine's complicated. That's probably the easiest
why it's
answer.
So complicated. I mean, we know that working in the spine. Like anyone that's just like, well, spine pain's simple. You're like,
it's
you
not.
haven't worked in spine very long.
There's a lot of reasons. I think a part of it is that a lot of the spine problems present similarly, right? How many times have you seen a patient? What are you coming in for? Back pain. Mm-hmm. Pretty generic. And again, I've had back pain. I've had sciatica. I've had the whole radiating, burning leg pain. It is truly hard to describe, mm-hmm. right? It's hard to really tell someone, well, what is it that you're experiencing?
Yeah.
Add to that, 5 or 6, 7, 8 different sources that can all present similarly. It makes it really complicated. Mm-hmm. And so I think the challenge with spine pain is that we have a lot of really good diagnostic tools, right? We have X-rays, we have CT scans, we have MRIs, nerve conduction studies. We have all these tools in our tool belt to try to figure out what's going on. It doesn't necessarily mean we have to use all of it, but part of it is that there's certainly, I think historically some reluctance to use those things mm-hmm. until people have suffered for a long enough period of time, which, again, if you're in the garden and you overdid it weeding last weekend, I think that's okay waiting.
Let's spend some time there. Why do the clinical practice guidelines kind of steer away from getting imaging early on?
Yeah, I think there's historically good reasons for that. Obviously there is the concern of, I think originally there's not that many resources for MRIs and CTs, right? And so mm-hmm. certainly don't want to inundate those resources. That's not necessarily the case these days. There's MRI centers all over the place. Mm-hmm. The other thing too is that I think there is a lot of maybe a lack of education there, in that the last thing I'd want to do is to get an MRI and for that MRI to show a whole bunch of stuff that may not be relevant to what's going on, and for
you just created 5 problems for
right,
this patient.
Exactly, right, and that's what I tell a lot of my patients is that a lot of the people we work with, we review thousands of MRIs personally a year, mm-hmm. Including both the radiology report but our own interpretation, right? I love looking at these images to kind of look for what I'm looking for. Mm-hmm. 95%, this is just kind of my interpretation, but the vast majority of horrible looking findings in the spine may not mean that you have symptoms from it.
Yeah.
A couple times a year, I'll see patients with a brand new fracture in their spine that has absolutely no pain, right? And so the last thing I want to do is to treat the image, right? Yeah. We're here for the patient. But the opposite...
we're actually going to fuse that portion of the spine because it's broken.
Yeah, but they're like, but I don't feel anything, right? Mm-hmm. But the opposite is also true, right? Where we get an MRI and it doesn't look particularly impressive, or whatever imaging study we have, but it doesn't mean that these patients aren't hurting.
Yeah.
We have to do a better job of correlating. So I think that's probably the hesitation that some people may have had in the past.
And by correlating, you mean we here's your pain, and this is what we see on MRI at that level.
Right. On that side,
there's correlation that could be happening there.
Yeah.
And then we'll use diagnostic tools like an injection. So say you had some degenerative change at the L4 region, mm-hmm. and we anticipate based on palpation or X-ray, that's your spot that's painful. And then you inject it and say, oh, it felt better. Then you're saying that's the correlation, right?
Yeah, or to confirm it, right?
Degenerative changes all up and down the spine, and you're like, oh, now we created 5 more issues in your mind.
Yeah, exactly. And then what happens is people say, oh my gosh, I can't get out of my couch, right? If I move wrong, I'm going to fall apart.
Yeah, and my spine's
and
degenerative. I got degenerative joint disease.
You hear that all the time. And again, I don't want to detract from that. There's certainly patients that have a lot of pain from that.
Yeah.
But it does not mean that they shouldn't be moving, right? We need to figure out how to get them where they need to be.
Absolutely. And it's so hard to determine the root cause of the pain. Sometimes we do have to treat the symptoms to get to the root cause, because sometimes it can be so diffuse and so whether it's referred or radicular. Referred meaning, like, say I had a heart attack, and where do you typically feel that? You feel it typically in the shoulder.
Right. Yeah.
Why? Because it's a referred pain. It's going somewhere else. The heart isn't directly innervated with sensation, so it refers somewhere else. And that's why the back can be so tricky sometimes, because even knowing the root cause is here, the symptoms might be way down your leg.
Yep, absolutely.
And how are we determining that? Well, it's a little bit harder than you'd think it would be. And we use these diagnostic tools just like a mechanic on a car.
Yeah.
Your car's not starting. There could be 5 reasons wrong.
Right.
Is it the starter? Is it the alternator? Right? Is the battery cables hooked up right? Is your battery dead? Right? Those are diagnostic tools that we use for the spine. Tell me about a few more diagnostic tools that you use to determine, let's just say someone has had back pain for a year. They've been through PT, they've been through chiropractic, acupuncture, it's persisting. What are some other diagnostic tools and things you're thinking about that could be the cause of their pain?
Yeah, so generally, if it's ongoing for a long time, I'll typically start with X-rays and MRI to just at least
they've been through kind of that conservative stuff.
Yeah.
They've got to you now.
Right. So we'll get images, try to figure out what's going on there. If we see specific pathology, there's a couple of things that we typically go through. If we see kind of disc or pinched nerve issues, we'll try an epidural injection, and there's different ways we can do it, either kind of a broad ranging type, or we
it's minimally invasive epidural.
Yeah, and generally people do very well with it. They're all image guided, very generally a very well tolerated and safe procedure.
How do you usually educate patients on that? It's not very invasive, it's safe. What other things are you saying? When people hear epidural, they're like, ooh, epidural.
Right. Or they think, oh my gosh, I'm not having a baby right now.
Yeah.
Why are we doing this?
Yeah.
So, the epidural space is really kind of a protective fat layer that lays on the outside, kind of in the spinal canal where our nerves live. And it's a great way for us to essentially deposit steroid around those areas. So in patients that have inflammatory issues, either a herniated disc or kind of an angry nerve that's causing, radiating leg pain, that's a very safe way for us to put steroids
what
there
does
to
the
get it to calm
steroid
down.
do to the inflammation?
It helps calm it down, and so the steroids are anti-inflammatory, and so oftentimes when you have like a tear in your disc or a herniated disc, there's a lot of inflammatory or kind of irritating chemicals around that space that cause the pain.
Yeah.
And so we're
that's a huge, I want to really just pinpoint that. The chemical component to when a disc is compressed for a certain period of time, it leaks a chemical which can be very toxic to the surrounding nerves, which doesn't become mechanical pain. So mechanical pain we can correct in physical therapy, but a chemical pain we need to correct with chemicals, right? Would you agree?
Yeah, more or less, yeah.
That's kind of the back of the book summary, and that's why we use injections to help us, because when we get stuck in therapy, using a steroid injection to calm down the inflammation will help us move and get them to actually do the things that they need to.
Exactly. And that's part of the kind of the education I give patients too, right, is that when you have these herniated discs, there's 2 issues. One is that mechanically there's a herniated disc, right? And that's going to take time and physical therapy to get better. The other part, though, is that there is that chemical irritation, right? And for some patients, we need to calm that down before they're able to feel better to be able to do those other things to get them better.
Yeah.
And the way I frame that is that even if I did an injection and you felt 100% better, if we got an MRI that day, it's going to look exactly the same, right? That's still going to be there. I'm very honest with my patients, is that it's not going to make it look any better. You might feel great, but that is actually your opportunity, right? When you're feeling better, to participate in these things that's going to heal you over the long term.
Yeah, because ultimately you're getting in there to calm things down, to be able to move better, strengthen or gain mobility through that certain segment to take away the pain for good.
Yeah, absolutely.
Yeah. So say, for instance, we get the injection, they go to PT, the pain is still persistent. I mean, we use the term pain neuroscience. Tell us about what pain neuroscience is. Like, why do people get stuck in chronic pain cycles? And we'll talk a little bit about tissue damage.
Sure.
Like, when people have pain chronically for a long period of time, they think, oh, I'm causing tissue damage, but that might not necessarily be the case, right?
Right. I mean, so our body interprets pain as a warning signal. That's why it's there, right? You're doing something that you shouldn't be doing, touching something on fire or sharp. And I think in acute injuries that it's exactly serving that role, right? Stop doing whatever you're doing and rest and let things heal. Over time, though, if we have not done our job in terms of identifying what's going on, correcting it, or fixing it, there can be it can develop into this chronic nerve cycle. And part of that is something called neuroplasticity, right? Meaning that our bodies are constantly trying to send signals back and forth to try to figure out, well, is there something active going on? Is there something that is dangerous that we need to caution against? And if pain goes on for a long enough period of time, that doesn't work out well in our favor, right? Either we're not moving and we are starting to atrophy some of our muscles, which can be painful in of itself, or there's just some abnormal signaling and that we need to do something to try to break that pattern of pain.
Yeah, so say you're talking about this and a patient says, oh, so you're telling me it's all in my head.
Sure.
How do you have that conversation? Because ultimately, yes, it is in your head, but we're not saying that you're making it up.
Right.
It's literally something that's happening unconsciously. Your nerves are extremely sensitive, and our role is to desensitize those. Essentially, it's a car that the alarm, turns on when a leaf drops on.
Right.
Right? It's just so ridiculously sensitive. And it doesn't mean there's trauma anymore, right? This gal that I've been talking about, 8 months of back pain.
Yeah.
Is she still having trauma to her spine? It's a lot less likely, right? Yeah, she still could, but ultimately she's stuck in this pain cycle of these nerves being super sensitive and sending incorrect signals.
Yeah. One of the examples I like to use are patients that have had amputations, right? It's not, there's, a whole different science between phantom limb pain.
Yeah.
But if you think about it, that's the neuroplasticity I'm talking about, is that our brains are always trying to send signals and to receive signals back.
Yeah.
And just because it's not there visibly, right, doesn't mean that you're
and I can
making it
attest
up.
to that. I cut off the tip of my finger. I don't know if you know this about me, but this is my party trick. I can do the swing. I amputated the tip of that finger, but I had pain in the tip of my finger for almost 2 years.
Wow.
And the finger's not even there.
Right.
So how do we have pain there? It's purely what you're saying.
Right.
Yeah. Tell me, what are tools that you use to get people out of this pain cycle? What's the process?
Yeah, I think a lot of it is validation, right? Oftentimes, especially
telling them that it's not in your head.
Yeah, right. They say, "Oh my gosh,
you're not making this up.
Yeah,
it's
real.
You're
saying I'm making it up, or I've been told there's nothing going on, but there's got to be something, right? I'm feeling it. I'm hurting."
Yeah.
I think a lot of it is validation. It's like I believe you absolutely, right? I may not see something, but I totally understand that you're hurting. We just have to figure out what the options are for us, right, to get it better. There are lots of things that we can do, to try to target it. And a lot of times I tell patients, listen, there's not going to be one thing, right? There's not going to be one guy or one thing that's going to take care of this. Unlikely. And so the more ways that we can target this, the better off we are. Kind of the way I frame it is that, we may start some anti-inflammatories or even nerve calming drugs. That by itself may help 15-20%. Get you into some rehab. That may help 20-30%. Might do some injections if it's warranted. That might independently help 20 or 30. So really it goes
to this comprehensive
but it
system.
all adds together, right?
Yeah.
Independently, you may fail them serially and say, well, that only helped a little. I'm going to stop doing that and do the other thing. But together, I think it makes a big difference.
Yeah, and ultimately, someone's quarterbacking it.
Yeah,
right.
Exactly.
You have someone that's kind of guiding it. Like, okay, we're gonna try this. We're gonna pull it in. Right. It's not everyone developing their own plan. It's a coordinated effort.
Right.
How do you do that when you're quarterbacking it,
Sure.
in a sense? This is your patient. You started with them.
It's communication. Yep.
How does that look? Between healthcare workers?
So in this day and age, it should be really easy. We all have smartphones. It's easy to send a quick text. I don't need you to step away from your patients that you're seeing to answer me back for a phone call or anything like that. It's on your phone. But I think the way that we've done it is that we sit down with the patient. We say, hey, listen, this is our kind of plan, right? What are the things that you want to do? Here are the people I'm going to send you to, right? That are all experts in their particular field. And then once they've kind of started doing that, then we kind of touch base, right? Hey, I saw that I noticed that you saw my patient. What do you think, right? Are we on the correct path from your standpoint? And what are the things that we need to do next time we see them to check in and make sure that they're doing better? And that's been very, very successful.
Yeah. Why do you feel like that is successful for these patients that are stuck in this chronic pain cycle?
Precisely because it's difficult. Often, like I said, oftentimes they've already been to a lot of other providers, right, that have said, there's nothing I can do, or
that's the worst.
That's the worst, right? And sometimes
there's always something we can do.
There's always something you can do. I just might not be the guy, right? Or
but I can help you find it,
right? And I think that's kind of the hard part, is that they leave and they feel like, well, I didn't get any information out of it. And so even though there are a lot of conditions that I may not treat, I think helping them get to where they need to be is a huge part of it, right?
So crucial. If we are telling our patients that I got nothing else for you, I think we're really doing them a huge disservice.
Right.
If we don't have answers from them, who does?
Right.
We should guide them to the next person if we're not the person.
Right.
And then follow up. How did that go? Did you get the answers that you received? No? Okay. I got another resource, right?
Yeah.
But we have this connection in the healthcare community that we help guide people through it, because it's such a complicated system. People get lost and they give up on it, and then they just try random things and try to survive and lose their, all kinds of things in their life because of it. But ultimately, we're here to help them.
Exactly. One patient I saw recently came to me for kind of abdominal pain, and just kind of chatting with her. Really complicated history of bowel resection. She has an ostomy, and I from my standpoint, after I saw her, I thought a lot of it was related to her actual ostomy.
Yeah.
It would have been fairly easy to say, I'm not a colorectal surgeon, right? Go find one, see what they say. There's a great colorectal surgeon at St. Mark's that I actually went to school with in Wisconsin that came back here about 2 years ago. I just called him. I said, hey,
consult.
I've got this great, super nice patient. I think she has an issue with her ostomy. I don't know very much about it.
This is communication patients don't really know about,
right?
Right,
exactly. But
when I don't know something that's going on, I'm calling all my buddies.
Right.
I'm like, dude, Jay, what do I do with this?
But then that gets back to us, right? In terms of quarterbacking, whatever it is. So even though I don't think it's necessarily anything spine mediated or anything that I can do about.
Yeah.
I can at least ensure that she's gone to someone that can hopefully help her, right? Mm-hmm. And I know that I'm getting those notes back, and I can talk to my buddy and say, how's she doing, right?
Yeah,
making sure that she doesn't get lost to the system.
That is one huge benefit of working in a healthcare system like a hospital. Is I remember I could pull your notes, you could pull my notes. Yeah. Like we're all in the same medical chart system. One of the biggest complications with being in private practice is I don't have that benefit anymore.
It's tough.
You can't pull mine and I can't pull yours. And it was so easy for you to pull my progress notes or even my individual visit notes because you could see them all. It's like, okay, yeah, they said they're progressing here, digressing here, plateauing here. Mm-hmm. So before your visit, you already knew.
I already know exactly
they've been to therapy,
on,
right? But if they come to my practice, you don't know if they've even been to therapy unless I communicate with you.
But that's the beauty of communication, right? Mm-hmm. It's that it's very easy to send these little updates, and sometimes it's actually more informative than even reading the notes.
Mm-hmm. Oh, for sure, because then you just get the back of the book summary, the most important things. Because sometimes I'll write my note in reference to the insurance companies, right?
100%.
I'm like, that's just
there's a lot of stuff
the life
in
that
there,
we live,
right? There's like 10 pages of extra stuff, and you're really looking for those 2-sentence summaries, right?
Just give me the back of the book, 2 sentence. Are they progressing? They not? What are they progressing with? What do they need? What do you recommend?
Yeah, I remember working in the ICU and getting some transfers, and one of them I remember this patient came in with 3 hefty garbage bags full of notes. And I was an intern, so my job was to go through it. They were just vitals from her stay and like 0 clinical information, right? And so that's what makes it tough. But having these conversations, right, and being able to just pick up the phone and talk to someone, So helpful.
In less than 30 seconds, too.
Right. Doesn't take much time out of your day
and then
at
you
all.
can guide the care that you give the patient is expedited.
Absolutely.
We don't have to go through 10 minutes of questioning.
Right.
We can just dive right in. This is what I heard from your therapist. Is that accurate? Great. This is where we're going to go next.
Or, and instead of, well, I think he said something about like my hip, but I'm not really sure,
I love that. Well, any other things that come to mind when you have someone that's stuck in this chronic pain cycle? What does education do for them? Because most of these patients, I've read a lot of studies on pain neuroscience. They improve just with knowing how pain works. Tell me how that works.
Yeah, I think the education piece is huge. Getting patients to recognize that there is not necessarily any active instability or fracture or trauma that's occurring.
Mm-hmm.
I think number one, frees them from the fear of movement, right? And a lot of it is that they are hurting likely because they are not moving.
Mm-hmm.
We're designed to move. I'm sure there's days that you've just sat around the office, right?
Yeah, all of us.
On the computer. And
we've been on an airplane for 5-6 hours.
Feels
like
awful.
Terrible. Stiff.
Right. So I think freeing them from that fear is a huge part of it. But then also is just that guidance of what am I supposed to do, right? I mean, this has been going on for a long time. I'm afraid to do this and that, or I haven't been able to pick up my grandkid for like 3 years, and that was a huge dream of mine. Just kind of figuring out what their goals are and getting them there. I think even that conversation itself can really help break that cycle.
Yeah, absolutely. How do you get away from, a patient comes to you and they're terrified, they think they're doing damage to their spine, they think their spine is fragile, they don't want to move. Where do you start with that conversation? They're fearful. It's a real thing.
It is tough. The validation's a big part of it. And then I think, again, educating. Going over the imaging together, going over all of their studies together, and kind of showing them how the spine works is a big part of it. And then the other part that I love too is just having them, ultimately convincing them to go to a therapist, right? And to try a couple of the things that and see how they do.
Yeah, ease into the movements.
Right, exactly. And I think that's kind of going back to, having a list of stuff to do at home. That's the best part of working with good physical therapists, is that they recognize that, well, if we're doing this and it's hurting you, let's scale it back.
There's
right?
17 other ways to do that, and to break it down, make it easier.
And I think showing patients that oh my gosh, I never thought about moving this way and avoiding pain this way is a big eye-opener.
Yeah.
The other thing I love telling some of these patients too is that, if there's an issue with scheduling and going to physical therapy, or if you just don't know where to start, go to a pool.
Yeah, get in a pool, get moving away, and get unweighted.
Right, and I tell them, you don't even have to swim.
Buoyancy is a powerful tool.
Just get in, walk around, and that a lot of times.
And then they get out and they feel really heavy, but it feels amazing. Right. I mean, you go into waist high is 50% of your body weight, right? So you're unweighting your body to your chest line is 75% unweighted, right. So 25%. So you can literally offload your body, and there's something about the buoyancy. It's pushing on your skin, similar to a child that has autism that wants to feel compression, feel safe, right? So when our nervous system is very hypersensitive, that compression on the nervous system, on our skin, feels good and calms it down. It's a parasympathetic response to our bodies.
Yeah.
So I used to do aquatic therapy all the time. We had it right across the street from our South Jordan clinic, and we'd go over to the pool. But yeah, it's a powerful tool, especially when they're really stuck in that cycle. Any other recommendations for these chronic pain patients? And I really want to highlight interventional pain specialists. Why do we call it interventional?
That's a lot of what we do is
interventions,
right? So we do things like epidural steroid injections, joint injections, radiofrequency ablation, neuromodulation.
So these are pretty much all of the on the conservative end, right? This is the
Relatively
stuff we
speaking,
should be
yeah.
trying before surgeries, right?
Yeah.
We think about like entry points to care. What's the most conservative options first, to then more invasive options,
Yeah.
and then more permanent options, right? Why would you ever start at the end? Let's start you at the most conservative options first, and then work your way through if you're not progressing with those other things. Any other things? We talked about radiofrequency ablation. Tell me what that is, by the way.
So radiofrequency ablation is a procedure where we essentially ablate or deaden some of the sensory nerves. And so in patients that have...
So it's not a motor nerve, not what controls your arms or legs. So, it's what you feel.
Correct. Little tiny nerve branches that, their job is to essentially sense pain to some of these joints that, say someone has really, really severe arthritis in their back, right? That's probably the most common thing that we see in terms of radiofrequency ablation. If that joint is just not going to get any better, and they've done all they can in terms of rehab and core strengthening, then ultimately, if they do need it, we can certainly try to ablate those areas.
Is that permanent? A lot of our patients think like, oh my gosh, you're going to cut a nerve. I'm going to be doomed to destruction.
And one of the questions I get all the time too is that, if we deaden it, I can't feel pain in my back. Am I going to do something?
Am I going to get hurt there?
Right, I'm going to hurt myself,
feel
right? And no, it's very unlikely.
Why is that? A lot of people don't know how nerves work.
Yeah.
Why is that not going to just, kill sensation to that whole area?
Because we are targeting very specific nerve branches. And so there are, you have your spinal cord. It sends off nerve roots. Those nerve roots have a mix of both motor and sensory fibers. Those nerves themselves even split into smaller and smaller nerves, right, all the way to the level of the skin. And so, over the last couple of decades, we've really targeted just the sensory branches to primarily pain. Right?
Pretty incredible.
Yeah, and we're able to target them pretty well.
I mean, just like the refinement that you guys use to get that small nerve. I remember being in PT school, and we dissected a whole human body, and I knew I was not a neurosurgeon when they told us to find the brachial plexus, and I told my lab instructor, I'm like, I can't find the brachial plexus. I'm looked everywhere, and he pulls out something that I cut out, and he's like, it's in here.
It's in here. That's great.
And I'm like, the whole brachial plexus is in there. I had literally cut the whole thing out, like, because the nerves are so small. You think floss is small. We're talking even smaller than floss. Right. The level of skill you all have to ablate a nerve that small is absolutely incredible.
Yeah, and not only that is that there's all these emerging technologies, where ablation's been around for quite a while.
Yeah.
We're changing our paradigm a little bit too, all right? Whereas ablation is what we consider a destructive treatment or technology. There's a lot of more kind of rehabilitative or modulatory science now too, where instead of ablating those nerves, we're actually using small kind of wires to stimulate those nerves, and to try to treat back pain as well. And so I think one takeaway for these chronic pain patients is that they may have had consultations years ago, right? But and there may not have been a ton of options. But the speed at which at which we have gotten new technology in the pain realm is impressive.
Yeah, absolutely. There's thousands of research developments going on right now. Finding the next best thing. How do we treat this better? And development. And then these guys are graduating school and coming out with these new things. Right. And ultimately, if you tried something 10 years ago, it's way outdated.
Right.
There's a lot of advanced level treatments for you.
Yeah, even 5 years ago. They've been researching it for a little bit longer than that, but clinically speaking, 5 years ago when basivertebral nerve root or Intercept came out, that has been a huge game changer. And so that is a completely new target for us to treat these patients that we previously said we don't really have anything.
Yeah. What as we kind of wrap this podcast up, what last pieces of hope would you hope to give to these patients that are just lost, and they are kind of sick of the healthcare system? They've kind of feel like they've done it all. What hope would you give them?
Yeah, my message would be that there's a I think, a new wave of how we approach healthcare now. Just like you alluded to before, right? Instead of us telling patients necessarily what to do, I think the new approach now, and I hope that a lot of the new graduates and new people entering the space should be hopefully focusing on, is that we should really see our roles as educators, right? We should really be educating patients on what is going on so they understand why they're hurting, and then giving them the options and working together as a team. And I think that shift and this whole team-based approach has really changed the outlook on a lot of these patients.
Yeah, absolutely. I love that. That's really good insight. And then my other question is, if there's something you want to improve in the healthcare system, what would you say it would be?
I think
what do you hope to change in our system?
Yeah, we're doing better in the things that we're doing now, but I think we can still go a long ways in terms of communicating with each other.
Yeah.
It is not difficult, honestly, to pick up a phone or to text, and I really want to break down that barrier of being fearful to talk to someone who's treating the same patient as you. The other thing that I always kind of tell my patients too is that if I can't really figure it out, I am happy to talk to my colleagues and have them evaluate, right, or give a second opinion, a third opinion. I think one thing that we need to kind of let go a little bit of is ego. At the end of the day, I just want this patient to get better. I don't care who figures it out. If it's me, that's great.
Yeah.
I feel great.
Going back to that Olympian patient, I called her athletic trainer, and her athletic trainer was very defensive and said, "Is this really what the patient wants?" I said, "We're just going to take a break from athletic training for a little bit. It's been 8 months. We haven't really got where we need to go. We're just going to take a break."
Yeah.
And she was like, is that really what the patient wants? I'll call her, because she didn't trust me.
Sure.
Right? She's like, I'll call the patient and make sure I have the conversation with her to make sure that's really what she wants. And the patient was on the back end telling me, like, I just feel bad. I just feel bad to tell her that I need to move on and I need to work with someone else. And she was terrified to tell this athletic trainer that we were taking a break. And I'm like, I can do that for you.
Yeah, but that's unfortunate, right?
I know. I'm like, she just has an ego.
Right.
Like, let it go.
Yeah.
Like, and I promise you, I'm gonna get her back to you too.
Right.
But I'm just gonna intervene for a small space in time.
Yeah.
But I love that. Like, let go of your ego.
It
What is the best for the patient?
Right.
Like, this is not me getting everyone better. I cannot get everyone better in my world.
Right. And I think that's totally unrealistic, right? But that is something that sometimes we just kind of feel like, oh my gosh, what am I doing wrong?
Yeah.
Right? Or
when ultimately it's the science that's failing them, not me.
Right.
Like, my job is to apply physical therapy. If physical therapy doesn't get them better, it's not my fault. It's my fault if I don't follow the research, or if I'm not investing in my skills or getting better every day, right?
Or if you just stick to the same thing.
Yeah, I didn't switch it
12
up.
months, right, exactly.
Or I didn't get the team involved.
Right, exactly.
But ultimately, I'm not the solution for everyone, and I got to be okay with that.
Yeah, I think that's perfectly fine. But
I love that advice. That's really good. Okay, man. Well, thank you so much for joining us, Dr. Luo. Yeah. Absolute pleasure to have you on the podcast. Great insight on pain neuroscience.
Yeah, thanks for having me here. It's great.